Hey guys, we're back with procedures in sectional anatomy. We're going to take 4071. This is lesson 2, module 2, however you want to say it, but our first topic is going to be imaging the thorax and the chest. We're going to cover all the major studies that we do of the chest, but first we're going to do an introduction and then a bunch of anatomy. So here we go. CT imaging of the chest presents a unique challenge because of the continuous motion of the heart and vascular structures. Multi-detector CT technology has allowed the entire thorax to be scanned with thin sections during a single breath hold, making consistent high-resolution imaging possible. And the ECG synchronization with multi-detector CT is another valuable tool used to reduce cardiovascular motion artifact and improve image quality. Post-processing techniques that we have, such as 3D and multiplanar reconstructions, can accurately display the pulmonary and the coronary vasculature. These new non-invasive CT imaging techniques can augment and sometimes replace the information provided from more invasive tests, such as aortography, pulmonary angiography, and coronary angiography. So we're getting pretty close to this gold standard with CT. Most thoracic protocols are performed while the patient lies in supine position on a scan table with the arms elevated above the head. Using the shortest possible scan time helps reduce the artifacts created by respiratory motion. And whenever possible, scans of the chest should be acquired within a single breath hold to prevent misregistration caused by uneven breathing between the scans. The thorax has the highest intrinsic natural contrast of any body part. The pulmonary vessels and the ribs have significantly different attenuation values compared with the adjacent aerated lung. In most adults, the mediastinal vessels and the lymph nodes are surrounded by enough fat to be easily identified, but because of the intrinsic natural contrast, IV contrast is not necessary for all thoracic indications. I'll give you an example of that is when scans are done for screening, detection, or exclusion of pulmonary nodules or primary lung diseases such as emphysema or fibrosis that are typically done without contrast. IV contrast is used to differentiate vascular from non-vascular structures as well, and to further characterize lesions by observing their pattern of enhancement. The use of IV contrast is typically requested by the radiologist to differentiate vascular from non-vascular structures, particularly lymph nodes, and to evaluate cardiovascular structures by seeing the inside structures and to further characterize lesions by observing their pattern of enhancement. The demarcation of the esophagus and the GE junction can be improved by giving the patient thin CT bearings shortly before the scan, but it's usually not necessary. I don't remember ever doing that for a chest CT. If we're looking at the GE junction, most of the time you're going to do a CT abdomen pelvis for that. But I guess it's something you can do to mark the pelvis for, the GE junction for. Routine chest protocol includes both soft tissue and lung windows to evaluate mediastinal structures in conjunction with the lung tissue. Scans extend from the lung apices all the way through the costophrenic angles, and sometimes including the adrenals to rule out certain types of carcinomas. But in my facility, it's routinely, the adrenals are routinely included on all CT chests, but that's going to be site-specific radiologist preference there. The patient's positioned supine with the arms raised over the head to reduce the artifacts from the shoulder area. And the data acquisition is typically performed at the end of a patient's full inspiration. So the recorded message on the machine or the technologist's voice is going to instruct the patient to take in a deep breath and hold it. Of course, this may need to be adjusted with patients who have a low tolerance for breath holds or intubated patients who are usually accompanied by respiratory therapists who can control the breath holds for the technologist during the scan if the patient's intubated. You need to use the smallest field of view possible. An alternative positioning of the patient is prone, and this will show air trapping when the patient has small airway disease, such as emphysema, which we'll talk about in a bit. Okay, the indications for CT chest include interstitial lung disease. Interstitial means the supporting structure or the tissue within the lung parenchyma in between the bronchioles. So interstitial is the supporting structure around the vessels and the bronchioles. The second indication is for detection of pulmonary masses, including embolism. The third, oncologic staging, cancer staging. Number 4, CT angiography of the major vessels, cardiac CT, and assessment of the airways. All these indications are going to be discussed in later lectures as we progress through the study of the thorax here. So the CT thorax is normally displayed in mediastinal and lung algorithms. The lung algorithms obviously to view the lungs, but you need to understand the difference between air-filled bronchi and contrast-filled vessels. Just like on a plain chest x-ray, the bronchi are too thin to show. So the so-called lung markings are really blood vessels, blood-filled vessels. And these are the solid white anatomy that you see dotting the lung field on the mediastinal algorithm. On this image here, these little white dots are vessels that are filled with blood. On the lung algorithm, the vessels become more apparent, and you can see them here. They're filled with contrast, and you can tell they're vessels because of the filling of with contrast. Unlike plain chest x-rays on a CT monitor, it's possible to window the image down. What I mean by that, or to see the bronchial walls, and what I mean by that is the window and the level are adjusted so that the brightness and the contrast are changed to be able to see the bronchial walls. So you can play with these windows here on the scanner, which I'm sure you've already done, and window it down, and you can see the bronchial walls compared with the vessels. So here, if you look here, this is a bronchus coming out. It's air-filled bronchus. I see where you can see it there, and then you got the vessels of contrast all around it. So the easiest way to do that too is to find the trachea where it's at the carina where it's bifurcating. Follow it out, and you'll find these bronchioles going out into the lungs, and you can kind of see the vessel, the bronchial walls, and things like that when you window it down. A bone algorithm is sometimes submitted to the radiologist for viewing, and these are useful to evaluate small airway disease, bone metastasis, and fractures. Bone algorithms are not used for the evaluation of small pulmonary nodules because they can give a false positive when the nodule appears calcified. And we'll discuss pulmonary nodule CT protocols in the pathology course because there's a whole section of that. For CT chest exams, to distinguish between pulmonary vessels and pulmonary nodules, it's necessary to submit MPRs, MIPS, or MNIPS, which we'll define these later in the course, but I'm just going to go ahead and give you a little brief definition here. MPRs are multiplanar reconstructions, such as sagittals and coronals. MIPS are maximum intensity projections. They're different. They differentiate surrounding pulmonary vasculature from true nodules, and then the MNIPS are the minimum intensity projections. They demonstrate air trapping in the trachea and the bronchial tree when they're used for the thorax. We're going to see examples of all of these later. So the window level and the window width for CT thorax for viewing lung parenchyma is a window level of a -450 and a window width of 1400. For mediastinum, it's a window level of 40 and a window width of 350. And then for bone, you're going to use a window level of 300 and a window width of 2000. So as I said before, the use of IV contrast is not necessary for viewing lung parenchyma for interstitial disease. However, IV contrast does have its usefulness for CT thorax, and it's used for evaluation of the mediastinum and or major vessels, evaluation of hilar or pleural abnormalities, evaluation of lymphadenopathy, which is a disease of the lymph system, which can be manifested in numerous lymph nodes, all the numerous lymph nodes and lymph system that flows through the thorax. CT angiography of the chest, or CTA of the chest. There's often significant artifact in the mediastinum due to iodine in the superior vena cava. Subclavian vein is susceptible to this artifact as well, and this is due to the fact that these vessels are low pressure vessels. So there's two ways to overcome that. You may have seen this when you scan the chest, and there's a bright SVC right at the heart, and the reason is it's a low flow vessel. Anyway, to get over this, to overcome this problem, you have two choices. You can dilute the contrast bolus with saline, or you can scan from inferior to superior, so the acquisition of superior mediastinum occurs after peak enhancement of the superior vena cava. This doesn't always work when you're trying to catch the pulmonary vessels. They highlight very quickly after the SVC, so you may not get there in time. The older scanners, we did have to scan from bottom to top, but we only scan the pulmonary artery area, the main vessel, so you probably get away with it these days. Anyway, and then, as I said, you can use an oral barium paste or thin barium to visualize the esophagus as well from CT chest. And then your venous phase, you're going to inject about 75 to 100 milliliters of contrast at about 2.5 milliliters per second. And then for arterial phase, if you want to catch the arteries, you have to be quick. 75 to 100 milliliters of contrast at 3.5 to 4 milliliters a second, or even faster sometimes. A non-contrast protocol for CT thorax called high resolution chest, or HRCT, is useful for evaluating interstitial disease. HRCT is a sampling technique, meaning that the image spacing is very wide. It's 10 to 15 millimeters between the slices, while the slice thicknesses are very, very small, from 1 to 2 millimeters. I don't know why I keep saying milliliters. So anywhere from 2 to 5 slices are usually taken at the lung apices, and then you move down to the mid-thorax, take 2 or 3 slices there, and then you go to the base of the lungs and take another slice, a few slices there. And that's all you do with that. No contrast, no major slices through there, no coronal cytos. Well, you may turn some coronal cytos in, but a very small sampling is all you're doing. But the diffuse nature of interstitial disease, which means the widespread nature of it in the interstitium, it allows for that wide range of spacing, and it also reduces radiation dose when you do this way. So you're basically just taking a sampling of that interstitial disease to give the radiologist a view of what kind of damage is going on throughout the lung. So a technique called static expiratory HRCT is used to demonstrate the air trapping in patients with small airway disease. The patient's instructed to suspend breathing at the end of forced expiration. An example of how this works is that you scan a patient with emphysema, they breathe in and the damaged bronchioles do not expand, so the air is trapped inside the dilated terminal bronchioles. The bronchioles can sometimes expand and become what's called bullae. You will see those and discuss them in the pathology course, but they get really big and they can rupture and cause issues and get infections in them and all kind of things. So, but anyway, there are some really nice images in DeMaio depicting the high-res CT. along with more information. So I encourage you to read DeMaio's explanation of that and look at those images. So we're going to look at next are disease conditions for which CT high-risk chest is useful to evaluate. And I've got a table here. These are important. Short definitions. I tried to shorten them down so you can remember them, but lung disease falls into a lot of different categories. So anyway, I'm just going to read these for you. The emphysema is an abnormal permanent enlargement of the airspace distal airspaces distal to the terminal bronchioles that we just discussed in the previous slide about how they enlarge and all of that good stuff. The bronchiectasis is widening or stretching of the airways. It's a permanent dilatation of the airways or dilating. Sarcoidosis is inflamed air cells that become stiff and they can't hold as much air. It's akin to scarring. Cystic fibrosis is a buildup of very sticky, thick mucus. COPD is a group of diseases, includes asthma, chronic bronchitis, bronchiectasis, and emphysema that obstruct expiratory airflow. Asbestosis is exposure to asbestos. The asbestos fibers get lodged in the terminal bronchioles, and there's a constant rubbing, and they make their way all the way to the end of the bronchioles, and they constantly rub against those sharp fibers of glass, basically, rub against the pleura of the lung, and it causes these big calcifications at the terminal, at the sides and the bases of the lungs and the pleura. And then number 7, the final one, asthma, and that's a narrowed airway. We're about to go through the anatomy of the thorax. We've covered all the basic scanning of the chest, all the scan parameters and all that good stuff. Now we're about to talk about the anatomy, and I thought you might find this slide helpful. As you look at those axial images, you can kind of refer back to this image to get your bearings on where the anatomy lies to help you remember it. All right, this slice is just above the lung apices. It's typically included in the CT thorax. The anatomy listed, starting anteriorly, we have the anterior scalene muscle and the sternocleidomastoid muscle. Medially is the air-filled trachea, and the esophagus is collapsed in this image. You can't see it too well, but it's right behind the trachea. Follow the yellow area. To the right of the trachea is the right common carotid artery, and then the left, of course, is on the other side. Below the common carotid, the right vertebral vein and the right vertebral artery are seen. Moving inferiorly and beginning anteriorly on the left side is the left lung. Anterior and coursing medially is the left subclavian artery. Above that's the left internal jugular vein. Medial to those vessels is the left thyroid lobe surrounding the trachea. And then again to the right of the trachea is the right common carotid artery. In this slice we're getting into the clavicles, and the right subclavian artery is transected twice by the slice here in different locations as it courses below the clavicle. Posterior to the right subclavian artery is the right vertebral artery. Here listed again is the left common carotid artery and the left subclavian posterior to that. And we see a posterior rib, and also known as the left scapula. On the right is the head of the right clavicle, the pectoralis major muscle, and below it the pectoralis minor. On this slice, above the left common carotid and the left subclavian arteries is the left brachiocephalic vein. We'll be discussing contrast flow throughout the body and the vessels of the chest and abdomen as well in the pharmacology class, so you'll understand the timing of the contrast bolus better and where it's at and where it's going to be. That'll help you in deciding delays and things like that on scans. Plus, it'll help you know what anatomy too. Again, noted on the right side is the right common carotid artery, right subclavian vein, and the right subclavian artery. This slice brings us to the top of the mediastinal area of the chest, beginning anteriorly. The manubrium of the sternum is in the middle. You begin to see the left brachiocephalic trunk. Posterior to that is the left common carotid artery and the left subclavian artery. We're getting close to their origins from the aortic arch. The esophagus is seen with a tiny amount of air in it posterior to the trachea where it's always going to be. And then the right brachiocephalic trunk is medial to the right brachiocephalic vein, and also noted as the axilla region of the chest. So deeper into the mediastinum on the left, we see the left subclavian artery anteriorly, and medial to that is the left brachiocephalic vein, and posterior to that is the left common carotid artery and the brachiocephalic trunk. And then laterally is the brachiocephalic vein. And this slide is through the region of the aortic arch. Anterior to that is the tiny thymus gland. You see that showing up there. That's in adults. It's going to be very tiny in the front. Pectoralis major muscle on the left is noted. We've reached the point where the right brachiocephalic veins join to become the superior vena cava, or the SVC. Again, noted at the trachea and the esophagus there. This slice demonstrates the great vessels close to their origins. Anteriorly is the ascending aorta, posterior to the aorta is the SVC, and posterior to the SVC is the right pulmonary artery, or the distal portion of it anyway. Bifurcation of the trachea into the right and left main bronchus is called the carina, and that's demonstrated here. It's most commonly positioned at the level of the right and left pulmonary arteries, and that's a useful landmark when you're trying to locate the pulmonary arteries for a CTA chest exam. Behind the bronchus and just anterior to the vertebral bodies of the thorax, the azygos vein courses through the thoracic cavity. It's most often right of midline, and as it goes through the thoracic cavity, and also noted as the descending portion of the aorta posteriorly. This slice transects the heart and demonstrates all four chambers. Anteriorly, the sternum is noted. In the heart, there's the right ventricle, left pulmonary vein is also noted posteriorly. The azygos vein is demonstrated again. The left atrium lies primarily on the left side, but does extend across midline. And then the right atrium is anterior to the left atrium on this slice. Closer to the apex of the heart, you see the left and the right ventricle. Notice the septal wall between the right and left ventricle and the thicker wall of the left ventricle there. You see this here is thick-walled left ventricle because that's the big pump of the heart. The right coronary artery is displayed, coursing around the right ventricle. You can see it going right here. And the esophagus is seen collapsed just above the descending aorta there. The pulmonary vessels are represented as white dots, as we talked about earlier. They're contrast-filled white dots in the lung area, not airways. Okay, this is another slide, that is very helpful in demonstrating the branches of the SVC and the aortic arch and how they all flow through the mediastinal and upper thoracic inlet into the neck. Kind of help you look back on that as you're going through all the anatomy. These next 5 slides are from Romans. I've kind of put you a reference coronal image up there to help you identify where the anatomy lies in the coronal plane. And that always helped me when I was studying cross-sectional anatomy, is to see it in 2 different planes, and that way you got your bearings. So I put the coronal slice on each slide here. These next 5. I didn't include all the thorax images from your book. These are images that I felt that had some more important anatomy on it. Look over these and know that anatomy and where it lies. And if you have any questions, of course, don't hesitate to ask. So I'm just going to run these through here and let you look at them. And you can follow up in your book. And I'm also going to have these online or on Moodle for you. This is a nice cross-section of the heart here, coronal, and beautiful image. But you see, you get the picture of the aortic semilunar valve, and then you have it over here, and very helpful to me. In this image, you can see the fissures showing up here. It's kind of hard to see on the long windows, but you can kind of tell right here there's no lung markings or vessels. That's where that line's at. Same thing over here. You can kind of follow it and trace it, and you see a little blank area where the fissures are. But this slide shows those different fissures separating the lobes of the lung in a coronal format. Each lung is partially transected by oblique fissures that separate each lung into superior and inferior lobes. The right lung is further subdivided by the horizontal fissure that forms a wedge-shaped middle lobe. And this horizontal fissure is demonstrated, or the horizontal fissure is not demonstrated on this slice, but you can see the right oblique fissure here, and then here's the left oblique fissure. And this is kind of your reference images of where you're taking these slices through. Slides 29 and 30 demonstrate the lung anatomy from a medial perspective. On slide 29 is the hilum structures, such as the right pulmonary artery, right main stem bronchus, and the right pulmonary veins. On 30, you can see the groove for the aorta imprinted here in the lung. In this slide, hilum structures are also demonstrated, and those are the left pulmonary artery, left main stem bronchus, and the left pulmonary veins. Also, that cardiac impression here where the heart lies is, you can see that. So that's our introduction to the chest. We're going to pick up next time with the CTA thorax studies, but I'm going to have these anatomy slides on Moodle for you. You can go through those, and it'll help you a lot better than just trying to scroll through this lecture. See you next time.